Today our topic of discussion is management of acute myocardial infarction or ST elevation myocardial infarction. So what is myocardial infarction, or commonly called as heart attack? So what is the definition of myocardial infarction? As you can see here that myocardial infarction is defined as acute cardiac pain due to sudden and complete occlusion of coronary artery due to thrombus formation. So as you can see here that this thrombus formation or atheromatous plaque, it can be formed in the main coronary arteries like the LCA, LCX, or it can be formed in the other coronary arteries that are smaller in nature. So the severity of the myocardial infarction will depend on whether the atheroscleromatous plaque is formed. As you can see here that this artery, this coronary artery, it carries blood to various parts of the myocardium. So when there is an atheromatous plaque formed, there is complete occlusion of this coronary artery. It leads to ischemia and cell death of the myocardium, or we can say myocardial ischemia and cell death, because when there is plaque formation, blood cannot flow to the myocardium that it supplies. Okay, so this is the definition of myocardial infarction. Acute myocardial infarction, it may be also be caused by other factors like hypotension or inadequate myocardial blood supply or vasospasm. So these are the other risk factors for myocardial infarction. Next, we will talk about the risk factors associated with myocardial infarction. So the first risk factor is age, particularly the old age people that are more prone to develop myocardial infarction. Second is males are more prevalent than females. And the risk factor is family history, hypertension, hyperlipidemia or hypercholesterolemia, diabetes mellitus, smoking, obesity, mental stress, polyunsaturated fatty acid deficiency, also the physical inactivity, elevated high sensitivity CRP, and elevated levels of fibrinogen in the blood and elevated levels of homocysteine in the blood. These are also the risk factors for developing myocardial infarction. So another risk factor is the low levels of antioxidant vitamins, and another risk factor is low levels of protein C and S. So these are the different risk factors that are associated with myocardial infarction. So here you can see the obesity, that is the single most common cause of myocardial ischemia or other cardiovascular diseases. So if we reduce this obesity, if we are controlling this obesity by lifestyle modifications, usually we can control hypertension, hyperlipidemia and diabetes mellitus as well. So this was the risk factors associated with myocardial infarction. Next are the clinical features of myocardial infarction. Whenever there is myocardial infarction, what are the clinical features, what are the clinical signs and symptoms the patient is having? So we can recognize this patient is having an active myocardial infarction, or this patient has suffered myocardial damage. So the first symptom is typical anginal pain at rest, and this is correspondence with anxiety, fear and apprehension. So also there may be sympathetic overactivity symptoms like nausea, vomiting, sweating and feeling of weakness. Another sign may be dyspnea or orthopnea and cough. Patient may present with cough. And there is dizziness, syncope or collapse. Or occasionally this patient that is having myocardial infarction, this can present with painless infarction. That is, the patient may not present with any signs or symptoms. So this is especially seen in those patients who are older, women and diabetic patients. So in these patients, it can be a painless infarction. That means there will be no pain at all. Next are the signs of myocardial infarction. What are the different signs by which we can identify that this patient is having myocardial damage or myocardial infarction or heart attack? So the first signs are signs of sympathetic overactivity. There is pallor, there is perspiration or tachycardia. So these three signs are the signs of sympathetic overactivity. Next, signs of myocardial dysfunction. So when they can be persistent with congestive heart failure. So what are those signs that are associated with myocardial dysfunction? These are the cold extremities, that is the hands and the feet usually, or the extreme the extremities of the body, they may feel cold, or there may be fall in blood pressure, that's hypotension, or the patient may be in shock, or especially in those patients the blood pressure will fall who are hypertensive, who are having high blood pressure, and in these patients you can see that there is less blood pressure or hypotension. Next sign is oliguria, so there may be less urine production in these patients. Next is low volume pulse and low pulse pressure, likewise quite first heart sound, that is S1. So S1, you may, when you examine these patients, there may be weak S1 or it may be quite altogether. Another sign is mid systolic murmur, which can be seen because of this mid systolic murmur can be seen because of the mitral regurgitation or the prolapse of the papillary muscles. Okay, so next sign is fine crackles at the base, that is S3, gallop may be there. So these are the signs of myocardial dysfunction. Next is signs of tissue damage. Here you can see that there are three signs of tissue damage, particularly fever, there may be leukocytosis, and there may be raised SED rate, that is the raised erythrocyte segmentation rate. Next sign is that on the examination of the heart you may find pericardial rub, and you may also find mid-systolic or pan-systolic murmur. As I have discussed earlier, that this mid-systolic or pan-systolic murmur, this can be due to the mitral regurgitation or papillary muscle damage. Also there will be soft heart sounds, and arterial gallop, that is S4, is common in these patients with myocardial infarction than S3, that is ventricular gallop. So in these patients you can find S4 more common than S3. Next is the diagnosis of the myocardial infarction. After you have suspected that this patient has likely has myocardial damage, so what you do, you first of all you will obtain an ECG, that is a 12-lead ECG. So on this 12-lead ECG you will look for ST elevation, whether there is ST elevation or not. Second is you can also do some blood work, that is look for the cardiac markers. So what are the various cardiac markers? That is CPK-MB, troponin, I and T. So these are the various cardiac markers that are elevated in blood after the patient has myocardial damage or heart attack. Next is on echocardiogram, you will find left ventricular global or regional ischemia, that is either whole of the left ventricle shows the signs of ischemia, or there is some part of the left ventricle which shows signs of ischemia. So you will find these findings on echocardiography or echocardiogram. Next is you can do imaging tests like MRI. So these are the diagnostic tools by which you can identify myocardial infarction. So these diagnostic tools are ECG, that's 12-lead ECG, cardiac markers, left ventricular global or regional ischemia on echocardiogram, and MRI. Next you can see here that the normal levels of these various cardiac markers, that is troponin I, T, creatine kinase, MB, and myoglobin. So these are given here, you can see here, and you can look for whether there is any myocardial damage or not. So the normal level here is given for each of these, and the abnormal levels may usually be above these normal levels. Next is that this troponin T and I are released into the bloodstream within 4 to 6 hours. So as you can see here, it is 4 to 6 hours of an myocardial infarction and remain elevated for about 2 weeks. So these troponin T and I, these are released after there is a heart muscle damage. When there is damage to the heart muscles, these are released into the bloodstream and they remain elevated for about 2 weeks. Likewise, CK-MB is released into the bloodstream within 4 to 6 hours and return to normal within 48 to 72 hours. So these are the various tests, diagnostic tools to confirm the myocardial ischemia or myocardial damage. Next is the management of myocardial infarction. So the management of the myocardial infarction is divided into three heads, that is management of uncomplicated acute myocardial infarction, management of complications of AMI, and secondary prevention of infarction. Next, here we have given an outline of the general approach you should follow for any patient who is having suspected acute myocardial infarction or ST elevation myocardial infarction. So here, as you can see, that first of all you will be obtaining an ECG, 12-lead ECG. So if this ECG shows ST segment elevation, next step is you are going to give aspirin, beta blockers or morphine to this patient, and the next step is that you will look for the time frame. If the time period is less than 12 hours, then you will look for three things. First is if this patient is candidate for thrombolytic therapy, that is if you can initiate thrombolytic therapy in this patient. Second approach is that if thrombolytic therapy is contraindicated in this patient, then you can go for primary PTCA. Next is if the candidate is not a if the patient is not a candidate for reperfusion therapy, then you can give AC inhibitors, nitrates or magnesium to this patient. Here, if the candidate is candidate for thrombolytic therapy, then you can initiate thrombolytic therapy by giving streptokinase or TPA or some other drugs to these patients. And after that, you can initiate AC inhibitors, nitrates or magnesium. So if the patient is not a candidate for reperfusion therapy, in that case, that means both thrombolytic therapy and PTCA, these are contraindicated in these patients. So you cannot initiate thrombolytic therapy, and you cannot do primary PTCA for these patients. So you have to go for AC inhibitors, nitrates or magnesium. Okay, for those patients who are not a candidate for reperfusion therapy. Next is, this was for the time period if it is less than 12 hours. So if the time is more than 12 hours, you will see if the symptoms are progressive or not. So if they are progressive, then you can consider reperfusion therapy. So the reperfusion therapy will be same like thrombolytic therapy or PTCA. So if the symptoms are not progressive, then in that case you will stay with the ACE inhibitor, nitrate and magnesium therapy. So this is the general approach that you should follow for any patient having suspected myocardial infarction or ST elevation. Next is the management of the myocardial infarction. So this management, first of all, we'll be talking about the pre-hospital management. So this pre-hospital management is divided into three subheadings, that is recognition of symptoms by the patient. Next step is rapid development of an equipped emergency ambulance to provide advanced cardiac life support. So this is particularly done in developed countries, where they provide an ambulance services that are well equipped with even thrombolytic therapy. So next thing is the transportation of a patient to a hospital. So you have to transport the patient to a hospital. So what are the various pre-hospital treatment measures that you can initiate for a patient? For example, you can follow routine measures, or you can give aspirin, nitrates or thrombolysis in these patients. So these pre-hospital treatment measures can usually be provided by the emergency ambulance. So if it is not available, then it means that you have to transfer the patient to a hospital. So the routine immediate measures, those include high flow oxygen therapy. You have to gain an IV access, and you have to do 12-lead ECG for these patients. So next approach is that you have to give nitroglycerin 0.3 mg or isosorbide trinitrate, that is 5 mg sublingually. So how much dose you have to give? You have to give this nitroglycerin, either nitroglycerin or isosorbide trinitrate. You have to give 3 to 4 doses, okay, over a period of 5 minutes. That is, you give one dose, then you wait for 5 minutes, and if the symptoms are not controlled, you give another dose. So likewise, you can do this over a period of 15 minutes, usually 3 to 4 times. And still, if the symptoms persist, then you can transfer the patient to the hospital. Okay, so next thing is that the routine immediate measures. Next thing includes analgesia and an antiemetic. So you can also give IV morphine that is 10 mg dose, okay, or you can give an antiemetic drug like Zofran, ondansetron or prochlorperazine. So these are the routine immediate measures that you can follow while before transferring the patient to a hospital. So next thing will be that if aspirin is available, you have to give aspirin in the dose of 75 to 310 mg daily. So this improves the survival by 25%. This aspirin is also called as poor managed streptokinase because it improves the survival by 25%. So if the aspirin is available, you should immediately give aspirin to these patients in the dose of 75 or to 310 mg daily. So the first dose should be given in soluble or chewable form because there will be rapid action. There will be a rapid onset of action if the aspirin is given in chewable or soluble form. Also, the patient might be having severe pain, so he might not be able to open his mouth or take the tablet form or capsule form of the drug. So in that case, you have to give aspirin in the soluble or chewable form. Next is you can also give clopidogrel in combination with aspirin. So this clopidogrel that is actually the dual antiplatelet therapy that should be given to all patients with ST elevation myocardial infarction. Or you can give prasugrel, that is prasugrel is actually considered to be superior to clopidogrel. So this is to be given in the 60 mg dose orally on day first. So on the first day you have to give 60 mg and then you can maintain the dose of 10 mg daily. That is, initially you have to give 60 mg dose, then you can give 10 mg dose daily. So this is for the prasugrel. But this prasugrel is contraindicated in patients with stroke or older than 75 years of age. So if the patient is having prior stroke or an active stroke or CVA, then you should not give this prasugrel to those patients or the patients who are older than 75 years of age. Next is the acute reperfusion by thrombolysis. Here there is one concept, that is earlier the thrombolysis, better the prognosis and maximum the benefit if it is given within 1 to 2 hours. So as here you can see that if the thrombolysis is initiated within 1 to 2 hours, then there will be maximum benefit. So this thrombolysis should not be initiated in patients with ST depression. You should keep in mind that if there is ST depression, then you should not provide thrombolysis to these patients. Next step is you have taken the patient to a hospital. So in the hospital there will be an emergency department or an accidental department. So what are the approaches that you should follow there for this patient? First of all, you should make sure that to give the patient a proper bed rest. Next, you should initiate oxygen therapy or you should give nitroglycerin. Also, you have to keep in mind that you should also give morphine to this patient. So this nitroglycerin is to be avoided in patients with hypotension or right ventricular infarction. So if the patient is having hypotension or right ventricular infarction, you should avoid nitroglycerin. And before giving morphine, you should make sure that the patient has already received sublingual nitroglycerin. So the dose of the nitroglycerin, as discussed earlier, it should be 0.3 mg, or you can give isosorbide dinitrate 5 mg over a period of 15 minutes. That is 3 to 4 doses you can give for nitroglycerin. So this nitroglycerin has to be given before you actually give morphine infusion to this patient. So you have to make sure that this patient has already received nitroglycerin before giving morphine. Okay, so morphine is for the pain that the patient might be having. Next thing is that you can give intravenous beta blockers, that is intravenous metoprolol or atenolol. So this metoprolol should be given in 5 mg dose every 2 to 5 minutes, or atenolol you can give this 5 mg given over 5 minutes, or you can give total of 3 doses for metoprolol or atenolol. So both of these drugs, that is intravenous metoprolol or intravenous atenolol, they should only be given if the patient has a heart rate greater than 60 beats per minute and if the blood pressure is more than 100 mm mercury and PR interval is less than 0.24 seconds. So these are the conditions for initiating IV beta blocker therapy in patients with myocardial infarction. That is, the patient should have a heart rate of more than 60, blood pressure of more than 100, and PR interval of less than 0.24 seconds. Also, you have to keep in mind that intravenous beta blocker therapy should be avoided in patients with heart failure or heart block or bradycardia. So these are the conditions where you should avoid intravenous beta blocker therapy. So next approach in the hospital will be that you have to give aspirin in the dose of 75 to 310 mg per day, or you can give clopidogrel 75 mg per day dose. So this has to be the dual antiplatelet therapy. So the dual antiplatelet therapy usually includes aspirin along with any P2Y12 inhibitor, that is clopidogrel or other drugs like prasugrel. So this dual antiplatelet therapy is indicated for 1 year for all patients with acute coronary syndrome. So this has to be given for at least 1 year in all the patients, even those patients who are having stent placement, that is drug eluting stent or bare metal stent. So it does not matter whether the patient has which type of stent. Irrespective of the type of stent, you have to give dual antiplatelet therapy for these patients for at least 1 year after having the myocardial infarction. Okay. So the next approach will be primary percutaneous coronary intervention, that is PCI. So the immediate PCI that is considered to be superior to thrombolysis if it is performed within 90 minutes, that is door to balloon time. So the PCI, if it is initiated within 90 minutes, that is also considered to be as door to balloon time. It is considered to be superior to thrombolysis. So it is more beneficial to the patient, that is PCI is more beneficial to patient than thrombolysis if it is done within 90 minutes. Okay. So next you will also give bivalirudin or an GP2B3A inhibitor like abscesimab plus an anticoagulant like heparin. So this in the patients who are undergoing PCI. Okay. So in the patients who are undergoing PCI, you can give bivalirudin, that is a direct thrombin inhibitor, plus any GP2B3A inhibitor like abscesimab or heparin. Okay. So this reduces the major thrombotic events in patients who are undergoing PCI. So this therapy, that is bivalirudin plus an GP2B3A inhibitor plus heparin. So this reduces the major thrombotic event in patients who are undergoing PCI. Next is you have to initiate thrombolysis or fibrinolysis. So you have to keep in mind that coronary thrombolysis preferably done within 3 hours, that is also called as door to needle time, help us to restore coronary patency, preserves left ventricular function, and improves the survival. Also, the mortality related benefit is maximum if the window period is less than 12 hours. Okay, if the window period is less than 12 hours. So beyond a period of 12 hours, there is no rationale or there is no benefit or mild benefit for initiating the fibrinolysis or thrombolysis therapy. So between 6 and 12 hours, it is shown that there is mild benefit usually for these patients between 6 and 12 hours. Also, the benefit is seen more in patients with anterior myocardial infarction and also those patients who are non-diabetic and the younger subjects, that is the patients who are less than 55 years of age. The benefit of thrombolysis or fibrinolysis is seen more in these patients, that is anterior MI, non-diabetic and younger subjects with less than 55 years of age. So thrombolysis, fibrinolysis you have to initiate within 3 hours, that is door to needle time. And beyond 12 hours, you have to remember that there is mild or no benefit, and between 6 and 12 hours there may be mild benefit with thrombolysis or fibrinolysis. Next thing is that what are the various drugs that are used in thrombolysis for initiating thrombolysis or fibrinolysis in these patients. So the first drug is tissue plasminogen activator, also known as TPA. Second is streptokinase, and third is an isolated plasminogen streptokinase activator complex. So these three drugs are the These are approved by Parenteral Drug Association for intravenous use in acute myocardial infarction patients. So what are these three drugs? Tissue-plasminogen activator, streptokinase, and APSAC. So these are the drugs that are approved by PDA for IV use in acute myocardial infarction. Next we will talk about streptokinase. So this streptokinase comes in the dose of 1.5 million units. So you have to give 7,50,000 units in the first 20 minutes. Here you have to keep in mind that this has to be given in IV infusion. So you have to give 7,50,000 units in the first 20 minutes, and in the subsequent 40 minutes you have to give another 7,50,000 units of streptokinase. So one thing you have to keep in mind that this streptokinase is antigenic, that is it produces an allergic response in the body. So the streptokinase side effects are mostly, that is allergic reaction may be there, or there may be fall in blood pressure, that is hypotension, or there may be antibody production. So these are the side effects of streptokinase therapy. So before initiating streptokinase therapy or while giving the streptokinase therapy, you should keep in mind these things, that the patient may be having an allergic reaction, may be presenting with hypotension, or there may be an antibody production. So if there is antibody production, you have to keep in mind that you have to keep this in mind before giving the another streptokinase therapy, because it may be ineffective, as the antibodies may negate the effect of the streptokinase therapy. Next is alteplase. So this is another human recombinant TPA. The advantage of this alteplase is that it is non-antigenic, that is it does not cause any antibody production, and it does not cause hypotension. But the thing is that it is more expensive than streptokinase. So you have to keep these things in mind before initiating the therapy. So after initiating the thrombolysis therapy, next thing you can do is heparin and thrombolysis. So the heparin is usually given as a 4,000 unit stat dose followed by 1,000 unit per hour. This has to be given after thrombolysis with streptokinase. That means you can initiate this heparin therapy after you have given streptokinase therapy, after you have already initiated thrombolysis in the myocardial infarction patient. So this has to be given in the stat dose of 4,000 units followed by 1,000 units per hour. So this is for the heparin therapy. So the next we will be talking what are the various contraindications of thrombolytic therapy. Here first thing is that it is contraindicated in active internal bleeding. Whenever there is any active internal bleeding in the patient, then we cannot initiate thrombolytic therapy in those patients. Or there is a previous history of subarachnoid or intracerebral bleed or cerebrovascular accident within 1 year. So within 1 year, if there has been any subarachnoid or intracerebral bleed or a CVA, we cannot give thrombolytic therapy in these patients. Next is if there is uncontrolled hypertension, that is during the presentation of the patient. If the blood pressure is 180/110 millimeter of mercury, then you cannot initiate thrombolytic therapy in these patients, or you have to exercise precaution in that case. Next is if there is recent history of any recent surgery, that is within the past 1 month, if the patient has undergone any surgical surgery, then you have to avoid thrombolytic therapy in these patients. Next thing is recent trauma, that is within 2 or 4 weeks, within the past 2 or 4 weeks. So you can also, in these patients, you cannot initiate thrombolytic therapy. Next is if the patient is having any active peptic ulcer disease, also in these patients it is contraindicated, and also in pregnancy and diabetic retinopathy, along with any previous history of aortic dissection, and also in the patients whose INR is greater than 2 to 3. So these are the various contraindications of thrombolytic therapy that you have to keep in mind before initiating thrombolytic therapy. So you have to evaluate the patient before giving any thrombolysis or before giving any fibrinolysis. Next we will talk about the treatment of the complications of myocardial infarction. So here In the one column we have given the complication, and here we have discussed how it can be corrected. So first is hypotension. So the patient may be presenting with hypotension. So how this can be corrected is that first of all you have to find the cause of the hypotension and treat it accordingly. For example, drugs like nitrates, beta blockers, and angiotensin converting enzyme inhibitors should either be stopped or their dose is reduced. So in that case you can discontinue nitrates, ACE inhibitors, or beta blockers, or you can reduce their dose. Next is you can give IV fluids and inotropic support if it is required. Next is if hypotension is due to rhythm disturbances, then correct the arrhythmia. Next is if there is cardiogenic shock due to congestive heart failure, that is mostly seen in most severe cases. So congestive heart failure, it is one of the most severe cause of the hypotension. So you have to treat that accordingly. That is, you have to treat the cardiogenic shock there. Next is the premature ventricular contractions. So this is the form of arrhythmia, premature ventricular contraction. This can be corrected by giving beta blockers or amiodarone. Next is ventricular tachycardia. So this ventricular tachycardia, this can be corrected by giving intravenous lidocaine, or you can give amiodarone, or you can give DC shock, that is direct current shock. Next is the ventricular fibrillation. So for this ventricular fibrillation you can give bretylium or amiodarone. So this is for the treatment of the arrhythmias associated with the acute myocardial infarction. Next is complete heart block. If there is complete heart block, it is mostly seen in 5 to 15% of cases. So how to correct this? You have to give either atropine, or you have to provide temporary pacing for these patients. But if there is a recurrent heart block, if the symptoms are not improved, that you have to consider permanent pacemaker in these patients. Next complication is ventricular dysfunction. So this ventricular dysfunction can be corrected by initiating ACE inhibitor therapy in patients, especially those who are having ejection fraction of less than 40%, regardless of congestive heart failure. So whether the patient has heart failure, congestive heart failure or not, you don't have to keep that in mind. What you have to keep in mind is that whether the patients, you have to look for the ejection fraction. If it is less than 40%, regardless of CHF, you have to initiate ACE inhibitor therapy in those patients with ventricular dysfunction. Next is pump failure. So here you can give fluid or diuretic therapy depending on left ventricular filling pressure. Also you can adjust the vasopressor or vasodilator therapy in these patients. Next thing will be the secondary prophylaxis of the myocardial infarction. So here you can control the risk factors and lifestyle modification. Also you can give beta blockers and aspirin. You can usually give these for lifetime, or you can give for at least 5 to 7 years after the myocardial infarction. Also you can give nitrates if there is angina, persistent angina, or left ventricular dysfunction, or there is recurrent ventricular tachycardia, supraventricular tachycardia, or any other forms of atrial fibrillation. So you have to give nitrates in these patients. Next is you have to consider revascularization therapy for these patients, especially in those who are having stent placed in them. So also you can initiate coronary artery bypass graft surgery if the risk factors are not controlled. So you can initiate these steps. So this was